Okay, terima kasih ya. Thank you to kita punya MC. Okay, Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wa hlul 'uqdatam min lisani yafqahu qawli. Uh, Assalamualaikum warahmatullahi wabarakatuh and good afternoon to everyone. Okay, thank you to organizer BestARi, Breast Cancer Awareness Research Unit, Hospital Universiti Sains Malaysia, and thank you to all participants today. And I believe we have here oncologists, we have radiologists, pathologists, medical officers, staff nurse, and as well as students. All right, and welcome everyone to a webinar, BestARi webinar. All right, and hopefully, within this about 1 hour, we can have something that benefit to our patient in terms of diagnostic and as well as in terms of management. So the topic today is on breast biopsy, the triple assessment and standard reporting categories. So just very brief about me, I am Dr. Wan Faiziah Abdul Rahman. I am the senior medical lecturer and anatomic pathologist since 2011. Okay. And I did my subspecialty training in breast and endocrine pathology in Queensland, Australia in 2015. And my research interests mainly in breast cancer, thyroid disease, and also in colorectal cancer. Right. So this is the place where I did my subspecialty in Australia, Gold Coast, and he is my endocrine teacher, Prof. Efrat Lam. Right. And my passion as pathology, so I have attended many courses that related for breast pathology. All right, and the last one, I together with my colleague Dr. Muharzudi and as well Dr. Muhammad Rafi, we have attended advanced breast diagnostic pathology course in Charing Cross Hospital under Imperial College of London in 2019, and we are very grateful because we have a chance to learn directly from a few great people, great person in breast pathology like our late Prof. Semi Sosha from Charing Cross Hospital, and Prof. Imad Raha, Nottingham Breast Unit, and also Prof. Sarah Pinder from King's College of London. And today, actually, what I'm going to share today mainly inspired from what I have learned, what we have learned from them actually. So just a little bit on the overview of the talk today. And as we all know that the triple assessment, especially in breast pathology, is the highest level of diagnostic accuracy by triple assessment. Although we know that the biopsy is a definitive non-operative diagnosis, but it should not be interpreted as isolation. And in breast pathology, the biopsy is the procedure of choice with greater sensitivity and specificity, not FNAC. Okay, and then the triple assessment must be followed by triple score for each categories, and therefore the diagnostic and management team would talk the same language. All right. And so at the end of this talk, I hope we should be able to at least to understand the importance of the triple assessment in breast biopsy and able to apply the biopsy reporting categories for timely diagnosis and prompt clinical intervention, and aware on biopsy tissue handling for proper reporting, and able to understand the rationale behind of each categories for a standard patient care. All right. And as we all know that when we talk about the triple approach, it must combine between the clinical, which is the history and the physical examination, and the imaging, whether from mammogram, ultrasound, or MRI, okay, and then pathology. For pathology, the HPE, I would like to repeat here, it is core needle biopsy. It is a needle core biopsy, it's not FNAC. The critical things about FNAC in breast pathology is that we cannot differentiate between the invasive or in situ malignancy. We can appreciate that the cell is malignant, but we're not able to appreciate whether it is invasive or in situ. So all these three must be combined. The result of this, must combine all these three results. Any discordant, it should be discussed in MDT, multidisciplinary team discussion. All right. So this is the real triple assessment must follow by the triple score. This is what it means by the triple score, whereby each categories would have their own score. All right. For example, the examination score from the history, from the physical examination, especially we might come up with a decoding or score from P1 to P5. The same thing with the radiology, whether they are using the mammogram, ultrasound, or MRI. Suppose we have to come up with a common score. All right, and we better use the R. Okay, but here we use a BioRats, which is I don't think it has it has problem. We can use the BioRats. After this, I will talk about it. And then for the histology here, we should give our diagnosis in terms of not only the specific name of that disease, but must together with the B score, whether the B1 or B5 to B5. All right. This is what the main point, the main things that I would like to discuss during this talk. Okay, we know that the MDT is the best consensus for further treatment. It is ideally done before patient getting results and before any treatment option discussed. And the triple assessment, which is the physical, the P, the R, and the B, will be applied and checked during the MDT, and to judge whether the biopsy is concordant with the radiological and clinical findings, and whether the biopsy is representative of the lesion or not, must be discussed in the MDT. And any discordance, especially between the imaging and pathology outcomes, the further action should be taken. For example, have to repeat biopsy or not, depending on the disagreement. All right. So we know that about the P, the physical score here. We know that distinguishing between the benign and malignant breast lesion solely by the clinical or physical examination is subjective, that carries a risk of uncertainty and error. We know about that. That's why we need further investigation. All right, but I think everyone know that doctor always lazy to write. This is what happened. This is what give us a problem. Although we are too lazy to write, but we need to prioritize our opinion in terms of the physical examination. So better we give score what our what we think about the patient based on the physical examination, then followed by the description about it. No need to write a lot. Just write the things that related to the patient from your physical examination. For example, the things that we always want to know, whether the patient has a mass or not, whether probable mass or not, it is very important. And then if there is a palpable mass, whether it's mobile or the size, whether lumpy mass or distinctive mass, and then the nipple discharge, any skin changes, nipple retraction, everything about the changes of the mass or the lesion need to write down. But no need. But we always have a request form that just write a throughout malignancy, breast lump throughout malignancy, which is I think don't give us a proper opinion about what for your clinical aspect. What do you think about the lesion? So better we put the P there, the score from the P from the clinical side. And then for radiology score, we know that radiology, we have BioRat system, which is breast imaging reporting and data system. It is a scoring system to describe whether for the findings from the MMG, the mammogram, the ultrasound, or MRI. Okay. In BioRats, what I know, we have 7 categories from 0 to 6. But no problem, because BioRats 1 to BioRats 5 is identical to B1 to B5. Therefore, BioRats can be used in R score. But the problem is sometimes BioRats in some center they just use for mammogram. If the patient doing the ultrasound, for example, there is no score there. So just write is the description, which is the findings from the ultrasound, which is and not given any the score to us to guide us to give whether to know whether they are suspicious for malignancy or they are thinking of benign or what. All right. So the scoring of the biorats based on the presence of the mass or not, and then the architectural distortion, the asymmetric density, and as well as the micro classification. So from this, give your R, okay? Give your R or your biorats, okay? And this is the example. We always have the history, very simple history, female 36 breast lump. Okay, very general. So we don't have any idea about that lump from the clinical side or as well as from the radiological side. We don't have any idea. But it will be different if you write female 36 breast lump P4R4. So although in terms of number, but it gave a very very good impact to us. Oh, they are thinking of P4, which is suspicious for malignancy. Also, the R4 are also the findings about thinking about the suspicion of malignancy. So they give a bright idea to us, okay? But the best thing, the completed request form should include the clinical details, the specifying the radiographic changes, and the site of biopsy, not the score only. But at least rather than nothing, we better have that score. In case you don't have time to write at all, can give that score, okay? And the reliable pathological interpretation requires that radiological details such as the mass lesion, the deformity, the calcification, and etc. All right, as well as the radiologist punya impression lah, the R3 ke R4, the R5. That's very that's the most reliable one, right? Okay, now we go to the breast core biopsy, which is the B score, the best practice of that. Okay, we know that there are various types of breast biopsy, whether under ultrasound guidance like this, or stereotactic biopsy under mammogram or MRI guided breast biopsy. All right, normally for ultrasound guidance is done for the mass, which is the palpable mass, to ensure the accurate sampling. And if it is a non-palpable, the mass has a coarse microclassification from the mammogram, where the ultrasound can detect that. But in this case, by right, we need to provide the tissue radiograph together with the biopsy. All right. And stereotactic guidance is mostly done for the case with the most indeterminate and suspicious microclassification, with the areas of the parenchymal distortion or stellate lesions and a small soft tissue mass which cannot be accurately visualized by the ultrasound, right? And the device used in the core needle biopsy, usually either two, the spring-loaded and the vacuum assistance. All right, the spring-loaded and a discharge a cutting needle at the end, and they insert into the breast tissue with a multiple needle insertion needed. All right, multiple, because they need not only one core, usually 2 or 3 cores. Okay, so multiple needle insertion needed, and usually used to sample the mass lesion. All right, but for the vacuum assistance, following the needle insertion to draw a tissue into the cutting chamber and to facilitate the sample collection. Usually from vacuum assistant, we get the largest specimen samples. And this permit the collection of the numerous contiguous samples with a single needle insertion. And usually used to sample the microclassification. All right. And as what you can see here, this is a various of needle types and a needle biopsy type, and a need based on the biopsy type based on the what needle we use. For example, for core needle biopsy and stereotactic core needle biopsy, usually we use this 14 gauge needle. Okay, this 50. So what we have is the tissue like this. But for the vacuum assisted core biopsy VAB, usually they use 11 gauge, the larger bore needle. All right. So we don't talk about this vacuum assisted excision. I don't think we have here. It's a very big chunk of tissue, just like an excised tissue, excised tissue, right? All right. So I hope everyone know what these things is. And this is actually the very small things, and it is actually the tissue marker clip. I don't know which hospital practice this, but this is good to have a tissue marker clip. This is usually it's made up of the whether titanium or stainless steel. It's very small. We put into at the end of the needle, and usually we insert during the biopsy. Why we need to put a tissue marker clip? Actually, there are various indication, but the important thing is that for some lesion, which is a very small lesion, it is might be have been removed during the biopsy. So sometimes we don't know where is the exact place to follow up. That's why we put this marker for further imaging. We know that that area we have done biopsy. Okay, there are many reasons why we put that, which is actually the main point is just to recognize the area that we have done the biopsy. All right. This is an example of the radiograph taken from the area that have been inserted the tissue marker clip. So we know the area have been biopsy. The lesion, the abnormal area, previous abnormal areas is that. Right, so can be avoid to biopsy the same area or something like that. All right, and a little bit about the handling of the core needle biopsy. If the tissue is the mammographic classification punya area, we must actually provide the specimen radiograph. A specimen radiograph means that the tissue, when we take the biopsy, that tissue actually we need to done some radiograph, and so that we know that confirm that tissue got the area of micro classification that. And that sample with the classification submitted separately and sample submitted entirely for the HPE. That's the best practice, right? And regarding the fixation, the tissue need a optimal fixation, and this is a paramount. Okay, immediately after take the tissue must fix into the formalin, 10% neutral buffer formalin, with a minimum 6 hours minimum, and maximum 72 hours. Meaning that if that tissue is really urgent, but you must allow the tissue well fixed first before proceed with the teaching. Before proceed with the immunohisto. Okay, for example, the ER, PR, and HER2 analysis are very crucial for the very crucial because when it is delay in the fixation or poor fixation, it can cause loss of antigenicity. The HER2 especially, it can have a negative. It can negative if in case of poor fixation, under fixated, right? That's very important for the fixation. And the radiological and clinical findings is a must, which is triple assessment, and the sample with micro classification must at least have 3 levels H and E. All right. And now we go to the reporting of the breast core biopsy specimen, the B1 to B5. This is not only pathologists to know, but everyone should know so that we talk the same language. All right. The reporting categories take into account purely the histological nature of the specimen. We give these categories purely on what we have seen under the microscope, meaning that the morphology of the specimen, not due to clinical imaging or what's on. Because that's why if let's say the biopsy found only the normal breast tissue, all right, but the clinical as well as the radiology thinking of malignancy, for example, R4, for example, but we cannot say that the tissue is not adequate. We cannot say that, okay? It is not feasible for pathological interpretation to judge independently whether a sample is adequate from the mammographic lesion. And for this reason, there is no inadequate biopsy category. In biopsy category, no inadequate tissue, all right? Because it requires multi-MDT. MDT will judge whether the sampling is adequate or not, all right? So this is, I'm showing here our textbook. This is WHO book. We call it blue books. We have a blue books, this blue book for every system. This is specifically for the breast. And as what you can see here, in our blue book, very detailed on the histology type and the diagnosis with the specific names. And this book, always change their term from time to time. This is the latest edition, the 5th edition. All right. Pathologists have to be up to date to every changes in this book. All right. For each specific histology type, they have their specific characteristic that determine their prognosis. All right. And then the pathologists tend to write the very specific diagnosis, but the problem is the management team not read this book. Okay, maybe the pathologist know a little bit about the update about that disease, the term or whatever, but management team not update about that. All right. This is what I'm going to share today on how to make this become make it easier for every team in terms of the management of the patient. All right. So this is how we should report the biopsy of the breast actually. We need to categorize everything, whether this is a normal tissue, the benign lesion, the B3, which is the benign but uncertain malignant potential, the B4, which is the suspicious lesion of malignancy, and the B5 of malignant, no doubt malignant, all right? So under of this B category, we have a long list of diagnoses, all right? Okay, we have this. So the pathologist should know which diagnosis is the B criteria, the B categories. Okay, this one, pathologist should know detail about that. But for the management team, you should know about which, for every B coding, what is supposed to be the next management. Okay, what should we do with this? Okay, that's why this thing actually make it everything easier, because without this coding, the problem is when the lesion is under B3. B3 is the most problematic cases. In fact, in other journals, many journals talking about the B3 lesion. We, the one who not practice this, sometimes blur what is a B3 lesion. Okay, but many articles talking about B3 lesion. B3 lesion is the benign lesion with uncertain malignant potential, and the diagnosis is what I'm showing here. There's a lot. Okay, there's a lot. So meaning that if the lesion is under B3 lesions, the management team cannot treat it as a pure benign. Just let it give a choice to patient. Patient don't want to remove, so we do not remove. No, I mean, just like for example okay. So B3 lesion need to go through one by one what the problem with the B3 lesion. So I will go through here one by one, the B coding and the rationale behind of that coding. All right. So for example, B1 lesion. B1 is a normal tissue. When the pathologist see only the breast ducts and lobules, or mature adipose tissue, or stroma only, so that one B1. All right. So we cannot give diagnosis. The tissue is inadequate. No, we cannot say that. The B1 lesion may indicate lesion has not been sampled. It's possible. Or maybe the lesion is, there is a lesion, but benign lesion like hamartoma or lipoma, which is only we can get on normal tissue. All right. Or maybe what they found, the microcalcification from the mammogram, whatever, is only the calcification from the involutional lobules, which is the atrophic lobules. Or maybe what they have seen, the microcalcification is only from the minimal changes from the fibrocystic change, which also can contribute to the calcification. All right, so this is what we are going to discuss. So all this, in any discordant, we need to discuss in the MDT. That's why very important. All right. So this is an example of what pathologists we will see under the microscope, which is the abnormality of the changes of the tissue, but actually it just indicate of the atrophic punya lobules. All right, these atrophic lobules can give us some abnormality, but actually it's just atrophy. All right. And how about the B2? B2 also something which is not no need to discuss further, because it is no doubt benign. Something that from biopsy you can see it is really benign. If fibroadenoma is a very classical fibroadenoma, never suspicious of the fibrosis ke apa, no area of cellular increase in cellularity ke apa. So it's well, and then especially for you can see at the border, sometimes it's complete. For example, intraductal papilloma, if it is a small intraductal papilloma and it is complete, so although it is a papillary lesion, but it's small and complete, so we can give a small intraductal papilloma, B2, no problem. Don't think more than that. Jangan fikir luar kotak dah. Okay, because it is complete. Okay, and the same thing, if you see the things, all this is really benign, so just give a diagnosis and write B2, no problem. Okay, but the problem is now is the B3. B3 is a benign lesion. Okay, benign, but we must put B3 because of certain things, because there is a risk of the risk to be upgrade. Upgrade means from the excised tissue, it may become B4 and B5. That's known for the B3. Okay, it shows heterogeneity for the lesion with a heterogeneity, for the lesion with a risk of associated of malignancy. Okay, and this diagnosis usually diagnostically challenging, and it require a further sampling. These are all the cases that fall under the B3 lesion, although it is benign, but we need to be careful, right? For example, the atypical ductal hyperplasia, the FIA, the flat epithelial hyperplasia, the lobular neoplasia. We call it lobular neoplasia because we cannot differentiate between the atypical lobular hyperplasia and the LCIS, but it falls under B3. For the radial scar or complex sclerosing lesion, but satu syarat without atypia lah. Okay, the papillary lesion without atypia, with or without atypia. Okay, the fibroepithelial lesion, the case of fibroadenoma that we cannot totally exclude the phallodes, right? And then the mucosal-like lesion, that is spindle cell lesion, and other lesion like macroglandular adenosis, the adenomyoepithelioma. Okay, semua tu under B3, right? So, kenapa B3 ni problematic walaupun benign, kita tak boleh treat betul-betul sebagai benign. Go. So, there are many studies done, apa ni, just to assess for the B3 lesion. For example, this is one of the study from 1,025 core biopsies. They collect from the 1999 to 2006, and they found the final histology, 25% from the B3 lesion is malignant. All right, it's a malignant. Okay, so that's why for all the B3 lesion, okay, this is all the B3 lesion. Okay, although this is benign, but they has different risk of upgrade. For example, they found that atypical ductal hyperplasia, 21% have a risk of upgrade, which is 21% turn to be malignant. Okay, malignant. And the same thing For example, the radial scar 36% is quite high to risk of upgrade to malignant. Okay, the papillary lesion with epithelial atypia 36%, the mucosal lesion they found at 21%. When they excise, it is malignant. All right, so that's why they put under B3, and the B3 usually the management is kalau dekat overseas they try to do the VAA, vacuum assisted excision, or if we don't have here, the best thing is the white local excision. But the tissue, the lesion must be excised, but not mastectomy. Okay. So this is an example what we are facing in pathology. For example, we have this kind of tissue. When we see under high power. Well, this is a papilloma, and it's small papilloma. Usually, it's multiple papilloma, and we found that it is a small papilloma, and it is complete. So no problem. We'll just put it P2. But in other area, for example, like this, we found the tissue, the cells hyperplastic with reform growth pattern, and it's showing some architectural atypia, and not sure whether this is ADH or LCIS. Not that sure. So this is, we cannot put it B2 anymore because we're not sure about UDH or ADH. But looking at the architectural atypia like this with a crypt reforming like this, we need to put B3. So this is B3. When it is B3, we need for further action. Be more careful. The same thing like this. We have something the hyperplastic punya lesion. Okay, it just like intraductal punya lesion, and it is look atypia, but it is not. It just partly membrane bound, which is not that complete, with the ill-formed bridges like this. So, we need to be careful. So this we can put B3, whether this is or query ADH or B3. Okay. But for the lesion that straightforward, it is benign. For example, this is a columnar cells. This is a columnar cell change. All right. Sometimes it very hyperplastic like this, hyperplastic. So if hyperplastic, it is columnar cell hyperplasia. But because of no atypia, nothing that suspicious for us, so this is columnar cell hyperplasia B2, columnar cell change B2. But if there is atypia, it becomes B3. The same thing with this lesion. This is a flat epithelial atypia. Flat meaning that the cell is round with round nuclei, with the apical snouting, and then lumen usually have the secretion, and it is flattened, only 1 to 2 level epithelial lining. All right, and it shows some atypia. So when this we diagnose flat, so we give the B3 because there is atypia. And pathology, there is a key on how to give to differentiate between the columnar cells change and the flat epithelial atypia, because this will cause quite problem to pathologists how to differentiate, because one is B2, one is B3. Okay, for this is one of the dia punya kaedah lah. Okay, for the columnar cell change, usually dia punya lumen, dia punya contour tu quite irregular inside. So if you can draw it, it looks irregular like this, so it is columnar cell change. But if it is you can draw very smooth dia punya contour, so it is flat epithelial atypia, which is B3. Okay, and then for another example, when we have this kind of lesion, we know that this is a lobules, okay? But we're not sure whether atypical lobular hyperplasia or LCIS, so we come up with a lobular neoplasia. There's no harm to call it lobular neoplasia. Once it is lobular neoplasia, we put it B3. Okay, when we put B3, there's a risk of to be upgraded whether B4 or B5. Okay, so that is understood already. Okay, so apa tu? in biopsy, we're not that sure, you can put the B3. Okay, but if it is a confirmed LCRS with the support with the immunohisto, and then there is a pleomorphism there, pleomorphic LCRS no more under B3, it is B5A. Okay, and when the lobular neoplasia mates with the ductal carcinoma in situ, when there is a DCIS, there is no more B3, it becomes B5A. All right, and then regarding the papillary lesion, okay, papillary lesion is something quite difficult actually. Difficult. We cannot actually give the accurate diagnosis from the core needle biopsy for papillary lesion. Okay, why? Because there are many studies done for the papillary lesion. We, in fact, from the biopsy, we cannot give category whether benign or malignant for the papillary lesion. The best thing, we just give a papillary neoplasm, papillary neoplasm and B3. Okay, this is because okay, for example, this is the intraductal papilloma with DIS. Okay, when the biopsy taken from here, if we got it from here, so the tissue just look like intraductal papilloma only. Okay, intraductal papilloma only. But if the biopsy done from this area, it looks like this, which is we will give a diagnosis of DCIS, papillary DCIS. You see how it very heterogeneous, can be heterogeneous in papillary lesion. That's why in papillary lesion, if it is not a complete lesion, from the biopsy we cannot give a definite diagnosis of a benign. For example, in this case, we gave a benign intraductal papilloma, okay, without considering another area might be increase in their grade. All right. Okay. Another example is this lesion. This lesion, when pathologists see this lesion and they found there's a central sclerosis like this with a fibroelastotic stroma, and with the glands here, the anthrax glands, they found and they did immunohisto, everything. This is a normal glands, all right? But it looks scary, just like infiltrating punya lesion. Nampak macam, sekali nampak macam malignancy, tapi actually it is a benign lesion. But this benign lesion has their specific name, which is, we call it radial scar, okay? If it is small, we call less than 10 mm, we call it radial scar. If larger, bigger size, more than 10 mm, we call it complex sclerosing lesion. You see how the pathology, the name, the histologic names, okay? This, although the name is menunjukkan benign, but we cannot confidently say it is B2 because why? In complex sclerosing lesion or in radial scar, there is a well known to be associated with the tubular carcinoma, associated with the DCIS, where it is at the periphery of the lesion. Sometimes the biopsy not cover that. The biopsy only take a part of it without taking the biopsy of the periphery of the lesion that normally associated with the tubular carcinoma or DCIS. All right. So if the lesion is very small and complete lesion, and we found there is no immature fibroblast, no cytology atypia, and no angulation of the glands at the periphery, so we can confidently say that it is radial scar. But still, if not complete, we cannot say B2. We must say B3 because of this reason. That's why radial scar or complex sclerosing lesion fall under B3, not B2. Okay. The same thing with the fibroepithelial tumor, that which is fibroadenoma, that's suspicious of this tumor. For example, there's some areas that show in a high cellularity, for example. Okay, this we cannot give a B2 anymore. We need to exclude a Fibro tumor. So we need to give a fibroepithelial tumor of B3. Okay. The same thing with the spindle cell lesion. Although we confirm from this morphology, oh, this is benign, you know, this is a myofibroblastoma. So if it is myofibroblastoma, it falls under B3. Because why? Because all the spindle cell lesion of the breast, we need to exclude for the most common one is a metaplastic carcinoma, the Fibro tumor, we need to exclude them. Okay, that's why myofibroblastoma, although it is benign lesion, but it falls under B3. Maybe the biopsy not cover everything. Okay, and then we move on to the mucosal lesion. Okay, mucosal lesion. Okay, although we found it is just looks like mucinous carcinoma. Okay, which is if we diagnose mucinous carcinoma, it fall under invasive malignant, which is B5B. But in biopsy, we just get a very small area, which is looks like mucosal lesion. So we put it mucosal lesion B3, and the team, management team, will understand that in a size lesion, it may be upgraded. Okay. This is the example of the mucosal lesion on needle core biopsy that have been misinterpreted as the mucinous carcinoma. All right. Sometimes we see the features like this, and with a lot of mucin, the background mucin with the cell here and there like this. We give a diagnosis of mucinous carcinoma, but actually it's just a cystic lesion that have been ruptured, and the cell here, the floating cells, is actually the cell lining the cyst. All right. Okay. So that's all about the B3 lesion. Okay. And then for the B4, B4 is a lesion that's suspicious for malignancy, meaning that at the first place it is malignant, but only suspicious. Why? Because the criteria not enough to call it malignant. For example, the lesion that contain probable cancer but crush or poorly fits punya core, alright? And neoplastic cells within the blood clots or with the or outer aspect of the samples dekat sample, it is confirmed malignant, morphologically malignant. Okay, tapi sebab not within the stroma, tak ada stroma, okay, so macam that only the cluster without any stroma ke, kita tak boleh confidently say it is a malignancy B5, just suspicious or very small foci of the invasive cancer. Okay, and the B5 is a malignant. Okay, it is a definite malignant punya nature lah, whether in situ or invasive. Alright, so the B5A is for the in situ, any grade of the CIS, and the LCIS for plumophic type only, and then for all the intraductal papillary punya lesion, which is start from the papillary DCIS, encapsulated papillary carcinoma or solid papillary carcinoma. This one, although dia punya name kat belakang the carcinoma, but you should know the papillary lesion, encapsulated semua ni, it is intraductal punya lesion. So dia pun treat as a in situ, okay, not invasive yet, unless memang kita nampak invasive and we report with an invasion, right? So, but for B5B, all the invasive primary breast cancer, including whatever cancer, lymphoma ke, malignant fibrosis ke, semua under B5B. No problem. Yang ni memang kita panggil straightforward lah. Okay. But for B5C is for a lesion, for malignant, uncertain punya lesion, sama ada invasive or in situ. Tak sure sama ada in situ or invasive, but it is malignant. Right. So we go to B5A, the in situ punya cancer. This is the most benefit core biopsy lah over FNAC, sebab that's why in most countries lah, especially UK, memang tak practice lah FNAC. Semua case, even breast screening pun biopsy, not FNAC. Okay, this is the problem lah, sebab FNAC tak boleh nak detect the invasive in situ or invasive. And you can no more diagnostic excision for diagnosis of DCIS because they have another method, which is a vacuum excision method semua tu. And possible invasion, kalau kita in situ, but with possible invasion, we can upgrade to B5C lah. Alright. And under B5A, as I mentioned earlier, it is all the DCIS, any grade, low grade ke high grade ke semua, including the DCIS with micro-invasion. And we know that micro-invasion means that the invasion less than 1 millimeter. Alright. So it's also under the 5A. And all the papillary punya DCIS lah, intraductal papillary carcinoma or papillary DCIS, encapsulated papillary carcinoma. Although sometimes ada area of invasion, but bila diagnosis of encapsulated papillary carcinoma is still under B5A. Alright. So what important about the DCIS ni? Penting sangat DCIS ni. That's why pathologists need to give specific architectural punya histology pattern lah untuk DCIS, because dia punya architectural histology pattern semua tu determine dia punya grade of the DCIS. And if it is high grade, make sure it is really high grade lah. For example, in comedonecrosis, that tally with the presence of the central necrosis with the high grade punya nuclear features. Don't overcall comedonecrosis just for the solid DCIS with just pantic necrosis. That one is not a high grade, not a comedonecrosis. That one is usually the solid punya DCIS with the pantic punya area necrosis. Kalau you tengok dia punya nuclear features not high grade, don't call comedonecrosis. It's still a solid punya DCIS which is low grade, paling tidak pun intermediate grade je. Okay, sebab kalau high grade punya DCIS, memang kita banyak benda kita kena tengok, especially area, kena go through one by one every area to need to search for the invasion. Alright. And usually, if it is reformed like this or micropapillary punya histologic pattern like this, usually it's low grade lah, low grade. Okay. This is example of the comedonecrosis with invasion with high grade punya DCIS. Usually high grade DCIS will be surrounded by the lymphoid. Okay, lymphoid punya cells. And if you carefully search, actually most of cases got micro-invasion. So where is the micro-invasion here? This is not micro-invasion. This is, you can see, this is well nicely still membrane bound. Mungkin dia punya cutting ke ataupun another DCIS. Okay, so the invasion is here. Okay, this is a micro-invasion. So this high-grade DCIS with micro-invasion still fall under B5A, not the not invasive, we not consider as invasive carcinoma yet. Okay, and for the LCIS, which is a plomophyte type, and the DCIS whatever grade fall under B5A. All right, and when we're talking about DCIS, one DCIS, why we bother about the DCIS? Okay, DCIS, this is critical to give at least the grade to. And in DCIS as well, we need to proceed with the immunomarker, ER, PR, HER2, and Ki67. Sometimes these markers can confirm whether it is really high grade or low grade, because low grade DCIS usually the ER, PR you show positive and HER2 negative, but the high grade DCIS, ER, PR negative and HER2 positive, and with the Ki67 is very high. Okay, and there is significant correlation between the grade of DCIS and the corresponding invasive punya cancer. Comedonecrosis should be used for high-grade nuclei and solid intraepithelial growth with central necrosis. All right. Microinvasion, when there is no foci more than 1 mm. It must be less than 1 mm. Okay. Okay. Another thing is the papillary lesion, which is intraductal papillary lesion. This is actually the most challenging cases for pathologists. In fact, 25% of breast pathologists' second opinion consults due to papillary lesion. Okay. The range of the papillary lesion can be from the papilloma to the DCIS to encapsulated to solid papillary carcinoma. Okay. And it almost exclusively intraductal lesion, rarely invasive. For example, invasive papillary carcinoma or invasive micropapillary carcinoma, it's different entity. It's not fall under the intraductal papillary lesion. Okay. An absence in myoepithelium does not necessarily indicate the invasiveness in papillary lesion. Okay. That's why in pathology we need to recognize the individual characteristic of individual papillary lesion. Okay. For example, this is the criteria how to give a diagnosis whether papilloma, papillary DCIS, encapsulated or solid papillary carcinoma. It should match with all these things with the support of the immunomarker ER, PR, and HER2. Okay. Remember that invasive papillary carcinoma and invasive micropapillary carcinoma especially is not under this category. Invasive micropapillary carcinoma is fall under the different subtype of the invasive carcinoma. All right. Okay. This is for pathologists especially where we need to see the morphology of the cells in terms of the epithelial to stroma ratio and the character of the front, the papillary front. That determine whether it is benign or malignant. All right. For example, in case of the intraductal papilloma here, we can see it is very broad punya front. Okay, you can see the stroma. Yeah, the papillary. This is fibrovascular core with fibrovascular core. Okay, the papillary formation. You can see the stroma quite broad, but in papillary carcinoma, you can see it's very delicate here and thin. Dia punya stroma, dia punya papillary front. Okay, dia punya quite slender. And another thing, look at the cohesiveness of the lesion. For example, in this case, in here, it looks still lagi cohesive for the benign as compared to the malignant. Okay, and for papillary lesion, it's rarely high grade. It always low to intermediate grade only. Okay, so for example, in this case, this is a papillary DCIS and this is encapsulated papillary carcinoma. One that can help us is dia punya P63 lah. When we do the P63, the myoepithelial cells stain at the periphery of the dia punya duct at the periphery of the lesion, but encapsulated papillary carcinoma, most of the cases there is negative, but it can be positive as well. But regardless of whether these are truly in situ or invasive lesion, they still continue to manage as DCIS. All right. And this is an example of encapsulated papillary carcinoma with the area of invasion within the capsules. That's normal for the encapsulated papillary carcinoma to have invasive area, especially within the capsules of the lesion. Okay, but still we cannot give a diagnosis of invasive punya papillary carcinoma. Is still encapsulated papillary carcinoma. Okay, unless it invade outside of the capsule, so we can say that it is encapsulated papillary carcinoma with invasion. Okay. And now B5B, I think no problem because it's straightforward all the list under the invasive carcinoma would be under B5B. Just to remember that DCIS with invasion, which is less than 1 mm, not under B5B, but if with invasion more than 1 mm, will fall under B5B. Okay, again, the B5B, all type of invasive carcinoma, including the lymphoma and malignant phyllodes tumor, and this all the lesion usually will give a specific diagnosis. Invasive carcinoma, no special type, for example. In fact, even although it is from the biopsy, we supposed to give the histology type, not invasive carcinoma only. If it is invasive carcinoma, whether it is NST or lobular carcinoma, mucinous, whatever, we need to give a specific from the biopsy, provided the biopsy is adequate lah. Dapat 3 core, 2 or 3 good cores. And in fact, the grading, we need to provide the grading, the Bloom rejection grading from the biopsy. All right. And for the B5C, it is cancer, but we don't know whether invasive or in situ. But to tell you the truth, this is rarely used. This is not to freely use for the safe side. It's often when a cancer without surrounding stroma only. Okay, it's rarely used. Okay. So now I just go through the example local cases. First, I would like to show the report that we usually practice. This kind of report, for example. You can see I know that most of us like to concentrate on the interpretation without trying to read the description, the lengthy description. But the problem is sometimes it's not only the description is the microscopic description is lengthy, but the comment below is also lengthy. This is what we want to try to avoid by doing the coding like this. We can at least avoid to give a lengthy comment, because you know sometimes comment orang tak baca pun, orang baca interpretation sahaja. Believe me, you know. For example, this is a Fibro epithelial tumor. That's suggestive of Phyllodes tumor. Suggestive of Phyllodes tumor. But why the pathologist wrote the suggestive Phyllodes tumor, you can read their comments. So for example, in this case, there are overlapping features between the Phyllodes tumor and cellular fibroadenoma. In this case, the presence of highly cellular stroma areas with increase of mitosis give impression of Phyllodes tumor. But another differential could be cellular fibroadenoma. However, the breast mitosis might warrant the diagnosis of Phyllodes tumor. Surgical excision is strongly recommended. Okay, so you nampak tak apa yang pathologist nak bagi tahu kat sini? Dia tak berani nak cakap itu adalah Phyllodes tumor sebab there's possibility of the cellular fibroadenoma. So it's end up dengan a lengthy comment, cerita macam-macam. Alright, okay. So, but actually, kalau kita betul-betul faham dengan coding semua ni, this is the example of the fibroepithelial tumor of B3. Kalau kita nampak B3 and then the managing team found it is a, tak kira lah nak tulis fibroadenoma ke fibroepithelial tumor ke, B3 meaning that there is a suspicious of Phyllodes. Okay, not straightforward fibroadenoma. Okay, so need to do something. Okay, for this case. All right. So the second report, I just give an example here. This is if we looking at the interpretation, it consistent with the Phyllodes tumor. Phyllodes tumor. So see comment what they write here. Okay. So from the comment, they wrote here the size is very huge, 10 times 10 centimeter, and the nature of the tumor itself show heterogeneous in its morphological appearance. Small biopsy may not entirely represent the whole spectrum of the lesion. As such, malignant Phyllodes cannot be ruled out. But actually, all these things tak perlu dah bagi tahu. Semua orang sepatutnya dah tahu the biopsy not representative the all lesion kan. Jadi tapi pathologist still lagi nak bagi tahu apa kebimbangan dia. So all their worrisome kebimbangan semua akan bagi tahu dekat komen. sambil scratch punya head lah, sambil tulis komen. So that's the problem. If we have the coding like this, so should be no problem. So this thing, kalau kita tak yakin dia adalah malignant fibrosis, okay? Tapi kita nak kata the possibility juga malignant because of these features kan. Just write fibrosis tumor of B3 because we understood already fibrosis B3 about berapa 30% from the S size boleh jadi malignant. Okay, can be upgrade into B4 or B5. Alright. But that will be different kalau even from the biopsy dah nampak the features which is apa kita panggil features of malignancy lah, distinctive features of malignant punya fibrosis, that different things. Kalau betul-betul dah nampak dah, so itu boleh confidently cakap malignant fibrosis B5. Okay, B5B no problem walaupun biopsy. Faham tak? Benda yang kita nampak terang-terang, this is malignant. Kita dah yakin walaupun S size pun tak akan tukar jadi benign balik sebab kita nampak dah malignant punya features tu. That's no problem, let's terus upgrade kepada malignant fibrosis B5. Alright? Okay, I hope I hope tak mengelirukan lah. Okay, and then the last report example. Okay, this is the the microscopic description. Of course, you tahulah panjang lebar lah pathologist akan tulis. And then just look at the interpretation. The fibrocystic change with adenosis and columnar cell change with atypia. Harap-harap managing team perasan lah ada atypia kat belakang tu. Okay, so although this is a benign punya lesion, fibrocystic change, when it is ada atypia, it's no more B2 dah. So this is a B3 lesion. Okay, walaupun panjang-panjang diagnosis, takut orang tak faham. Tapi at least apa tu, kalau ada coding ni kita tak miss. Oh, B3. So this is not B2. Need to do something. Alright. Okay. This is an example of one of the case. I like to always show this kind of case lah. This is a real case, our case. Female, 20 years old, very young female with breast lump for 1 month. With a strong family history of breast cancer. That's all the history lah. And no other history given. Tak ada history given. And then what happened? Looking at this kind of morphology, the MO thinking of something else. Okay, and they think he think that this is 20, very young, tak kahwin lagi for sure. Mana kahwin lagi 20 kan? Okay, so thinking of the something that malignancy lah, secretory carcinoma apa ke, so buatlah immunohisto lagi gini. But when by right, then I asked him to ask about the history. Let the thing history ke, pregnant ke apa. Tiba-tiba actually this patient on lactating. This is actually not a secretory carcinoma or whatever. This proliferation and hyperplastic closely packed lobules, that very juicy punya cells, you can see is actively secreting and hobnailing the cell. Dia macam tercabut keluar pergi dekat lumen semua. This is the typical of the lactating adenoma. Okay, from the history, which is a very poor punya history given, that cause a big problem to others actually. Alright, and in fact, lactating adenoma is not B3 ke apa, it's B2. Terus boleh tulis B2. It's very benign lesion and very common in lactating mothers. Alright, so walaupun dari umur yang muda tu tidak semestinya tak berkahwin lagi lah. Okay, so this is another case of the 27 years old, 22 punya millimeter size of breast lump. And from the history, this patient not pregnant, not on lactating. So this kind of lesion with a very looks very cellular, lobulated lesion with some atypia of the cells. So this is the thing that we need to be suspicious. And when we did P63, the cells are the lesion negative for the P63, meaning that this is not a normal lesion. And I asked him to do the S100, and it is very positive, strongly positive for the S100. And this is actually the secretory carcinoma, different morphology. Just I want to show how different the lactating adenoma from the secretory carcinoma. Okay, the secretory carcinoma, of course, it is happen in young, mostly in young women. Usually present as well-defined subareolar mass with a low nuclear grade nuclei. If high nuclear grade, no, apa tu, tak ada masalah. Boleh kenal. Kadang tu dia because of low nuclear grade. Okay, and the cell arranged in cribriform pattern with a vacuolated cytoplasm with a eosinophilic secretion in the middle of the cells. And then most of the time, it is S100 positive. And please do ERPR2. And mostly it is triple negative. And it is fall under triple negative punya cancer. And this is another case, another biopsy we have from the female 49 with left breast lump and nipple discharge. And there is no score given by the ultrasound, but they mentioned it is intraductal lesion, which is very helpful. Okay, very helpful. And then the complex cyst. Okay, so from that history, from that description of the radiology description, we give us the overview that this is intraductal lesion, and we have this kind of biopsy. This is a good core biopsy with a normal breast lesion on breast tissue only, but this is the problem. Okay, this tissue this actually the lesion without the stroma, and what we have only the blood like this. If we have the lesion embedded within the blood clot like this, thinking of the intraductal punya lesion. Okay, there is no stroma because the needle take only the lesion within the intraductal punya lesion. And this is, although we looks very cohesive like this, but it is arborescent. Okay, arborescent punya lesion. Okay. When we see under higher power, we can see it is actually papillary punya lesion with fibrovascular core, but it has a very broad, blunt punya fronts like this. Okay. And when we do the P63, we found it is stained all the papillae as well everywhere, meaning that there is a presence of myoepithelial cells within the papillary core and as well as at the periphery of the lesion. All right. So this is intraductal papilloma. Although from the biopsy we can diagnose intraductal papilloma, but whether we can put B2 or B3, this is what I want to ask everyone. This is the last slide actually. So if you do you think that the biopsy taken is complete biopsy without remaining tissue, other tissue? If you think so, you can say it is B2. But if it's the biopsy just a very one area, not representative of other area, maybe it is can upgrade to B3. So maybe the other lesion that not been but not biopsy, maybe it is different morphology. So to be safe, the papilloma, the papillary lesion, if it is a big lesion, this better B3. And another thing, all this need to discuss in the MDT, whether B2 or B3. This is the importance of the MDT. All right, so that's all the overview about the triple assessment and then the standard reporting for the breast biopsy. Okay, so I think about more than 1 hour now. So I believe there's of course there will be a lot of the question from all the participants here. Hello, the organizer, Kak Su. Saya boleh nampak chatting ke nanti? Hello? Hello? Any questions so far? Because I don't see any question from the Q&A here. Okay, there's one question here. This coding is gonna be standardized as in made into clinical practice guideline to be shared and understood among clinicians, radiologists, and pathologists. Yet we're not um, in our good clinical practice, in our clinical practice guideline, we're not yet um, this, but we have discussed this at we're going to discuss this because I have presented this among IAP International Academic Pathology members in Malaysian division, and we agree to what we call apply this and try to uh, make it one of the standard reporting. So it takes time. Everything will take time. Okay, thank you, Dr. Rahima Abdul Rashid, for your question. So, okay, saya serahkan kepada MC. Ada lagi ke soalan? This is my second talk lah pasal benda ni. First talk dulu on among pathologists, just to introduce the pathologists. And this second talk is mainly not only pathologists, for all management team, including the management team. Okay.
Apa?
Okay, there's one more question
Okay,
regarding
dengar tak?
encapsulated. Boleh dengar, siapa tu?
Dengar ke tak?
Okay. Okay, regarding encapsulated papillary lesion, if patient got thyroid lesion, is it possible? Saya tak nampak habis soalan. Is it possible meds from the thyroid? Possibility is yes, but possibility is yes because, but in term of morphology, it's quite different. The papillary lesion from the meds from the thyroid with the papillary lesion that primary from the breast. The possibility is yes, Dr. Kion. Thank you for that. Yeah. I think the participant can raise your hand if you want to talk. Because you cannot unmute your mic. When you raise your hand, the host will unmute you, and then you can talk. There's a icon of hand icon at the at somewhere there. When you raise, the host will allow you to talk. All right.
Okay. You.
And from Dr. Jamel Ganayam, between the IDC and RLC, which one is affected more by tissue biopsy adequately? Which one is affected more by tissue biopsy? I'm not that clear with that question actually. If you can we unmute Dr. Jamel Ganayam so that he can talk asking that question?
Okay, kita unmute Dr. Jamil Kanayan. Unmute. Okay. Dr. Jamil.
Assalamualaikum.
Waalaikumsalam. Okay.
Yeah, because I heard you during the session that you speak about the adequate tissue biopsy sometimes is not enough for diagnosis.
Yes.
So, so is that have particular effect on some type of cancers like the intraductal and intralobular. It is,
No.
for example, yeah, sometimes it's kind of cancer can be diagnosed with any level of biopsy taken.
Yes. Yes, Dr. Jamil. But for the invasive carcinoma, for the cancer, that's not much problem. Even from the biopsy, even the small, very small biopsy, if it is cancer, if it is a features of IDC of NOS, for example, so yes, it is. So we can confidently say it is IDC. All right. The same thing with the ILC. No problem. No problem. We can
Yes.
confidently diagnose even with a very small punya tissue. Yeah.
Okay. Thank you so much. This
Okay,
is my
thank you for
just
that
point.
question. Yeah.
No
All right.
problem. Thank you for the presentation.
Ada lagi tak soalan daripada semua peserta yang kita boleh ajukan pada Dr. Wan Faiziah? Okey.
We hope that we can
Ada soalan
incorporate.
lagi?
We hope that we can incorporate all this in our clinical clinical practice punya guideline. We hope this is the orang panggil apa, the first step lah yang saya buat untuk introduce dulu sebelum masukkan everything dalam. Itulah we will go up to that level lah lepas ni. Okay, Kak Su, saya serahkan kepada BestARi. Maybe kita boleh end the session lah.
Okey. Terima kasih Dr. Wan Faiziah. Terima kasih kepada Dr. Wan Faiziah atas proposal yang dia tadi. Sekali lagi saya ingin beringatkan kepada semua peserta yang mana yang telah berdaftar dengan webinar ini perlu mengisi borang balas yang telah dipaparkan oleh resepier bagi mendapatkan mata CPD. Sekiranya tidak mengisi borang maklumat itu, mata CPD tidak akan diproses. Okey, sebab kita tidak ada lagi soalan, kita akan menutup majlis ini pada petang ini. Terima kasih sekali lagi kepada Dr. Wan Faiziah atas perkongsian ini. Sorry ada masalah teknikal. Pihak kami dekat Universiti pun memang kakak macam lain macam hari ini. Dia kata ada masalah dengan internet hari ini.
Oh ya ke?
Terima kasih banyak-banyak Dr. Wan.
Tadi ada putus-putus ke masa saya bercakap tadi? Lama ke? Lama?
Ya, ada putus-putus. Tapi kita dah rekod lah semua tu lah.
Record. Alright. Okay. Alright.
Okay, semoga
So,
apa yang dikongsikan akan terima kasih semua.
Alright.
Terima kasih Dr. Wan.
Sama-sama. Thank you all the participants. Alright.